Now let's discuss about the topic hydrocele. Uh, a 45-year-old male named G. Kumar, resident of Upparpalli, farmer, illiterate, belonging to middle class, according to modified Kupaswamy, came to the OPD with chief complaints of swelling over right scrotum since 1 month, and he got admitted on 20th July 2026 and examined on 21st July 2026. History of presenting illness. Patient was apparently asymptomatic 1 month back. Then he noticed small swelling in the right side of scrotum while bathing, which is insidious in onset, gradually progressive over 1 month to current size. The swelling was associated with dull aching pain. It doesn't increase in size on straining or decrease in lying down or compressing it. No history of rapid increase in size. There was history of trauma 1 month back. No history of fever with chills. No history of exposure to venereal disease, burning micturition and discharge. No history of cough with expectoration, night sweats, evening rise of temperature. No history of rapid loss of weight. No history of leg edema. And there was no history of vesicles or exudation from the skin, and no history of ulceration, discharging sinuses, and difficulty in micturition or intercourse. Past history. No history of similar complaints in the past. He is not a known case of hypertension, diabetes, TB, asthma, epilepsy, and cardiovascular disease. Family history. No significant family history. Personal history. He is on a mixed diet with good appetite, adequate sleep, irregular bowel and bladder movements, addictions, alcohol since 20 years, monthly twice, and there was no history of allergy to any drug. General physical examination. Patient consent was taken. Patient was conscious, coherent, cooperative, and well-oriented to time-pleasant person. He is moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, colonical lymphadenopathy. Bilateral pitting edema was present, which was grade 4. Vitals. Temperature was afebrile. Pulse was 85 beats per minute, measured in right radial artery, which was regular in rhythm with normal in volume and character. No radial and no radial femoral delay. BP was 136 mm of HC systolic, 90 mm of HC diastolic, measured in right arm supine position. Respiratory rate was 16 breaths per minute. Local examination. Patient consent was taken and examined in standing position. In inspection, the swelling is present over right hemiscrotum, measuring 10 into 8 centimeters, which is pyriform in shape, extending from root of scrotum to base of scrotum inferiorly. Skin over the swelling is stretched with loss of rugosities. Penis is normal with and slightly deviated to left side. Left hemiscrotum appears normal and there are no visible cuff impulse, no visible peristalsis or pulsations, no ulcers, scars, sinuses or dilated veins. Palpation. There was no localized of temperature or tenderness. Right side scrotal swelling measuring 10 into 8 centimeters, pear in shape, extending from root of scrotum to base of scrotum inferiorly. The surface is smooth with cystic in consistency. Skin is freely mobile over swelling. Swelling is not reducible or compressible. Swelling is fluctuant and transilluminant. We are able to get above the swelling. Spermatic cord is palpable and normal. There is no impulse on coughing. Right testis is not palpable separately from swelling. Left side is normal. Inguinal lymph nodes not palpable. Systemic examination. Cardiovascular system S1 S2 no murmurs. Respiratory system normal vascular bed sound head. CNS no focal neurological deficits. Abdominal no distension, no organomegaly, non-tender. Summary. This is a case of 45-year-old male presented with right-sided gradually progressive scrotal swelling for 1 month associated with pain, with history of trauma priorly. On examination, there was swelling in the right hemiscrotum of 10 into 8 centimeters, which is pyriform in shape with loss of rugosities over skin. The swelling was fluctuant, transilluminant, and could get above the swelling. Provisional diagnosis. This is a case of right-sided vaginal hydrocele. So the viva questions here could be, what does association with pain indicate? Association with pain indicates that it could be epididymoarthritis. Here the pain is classical in epididymoarthritis. It doesn't increase in size on straining or decrease in lying down. Indicates it to root inguinal hernia or varicocele or lympharix. Rapid increase in size to rule out testicular tumors. Here there is history of trauma which could lead to secondary hydrocele. And fever with chills indicates epididymoarthritis actually, but recurrent fever with chills indicates filariasis. and no history of exposure to venereal disease, burning, micturition, and discharge. This is to rule out gonococcal epididymitis, and cough with expectoration, night sweats, and evening rise of temperature to rule out, and TB. In TB also there is enlargement of epididymitis, and there is secondary hydrocele, and rapid loss of weight to rule out testicular tumors. The tumors which are common in middle age are seminoma, and 20 to 30 years is teratoma. Legedema to rule out filariasis. Issue of vesicles or exudation from skin, it is seen in chronic inflammatory conditions of scrotum. Ulceration of discharging sinus is also seen in chronic inflammation like tuberculosis or malignancy. And difficulty in micturition or intercourse, this is also a type of complication. So these three are complications, and these are to rule out the cause, to know the cause. This is about the case, cause, complications. This is 3 C's of HOPA. And the patient was examined in standing position. Why standing position? To rule out or to look for swellings in standing position better, like hernia or varicocele. Here the surface is smooth. If swelling was nodule on its surface, it could indicate malignancy or hernia of hydrocele. Here there is no excoriation of skin also. In what is excoriation of skin? Here in long-standing hydroceles, in large hydrocele, the penis gets buried in scrotum, so the patient is unable to force the stream of urine. So urine dribbles over the scrotum, which leads to excoriation. Also, the rubbing of scrotal skin with medial aspect of thigh while walking, and application of any herbal preparation. This all could lead to excoriation of skin. Here the skin is normal, and cough impulse to rule out any hernia, like indirect hernia which spreads into the scrotum. And now palpation, temperature or tenderness. Tenderness is mainly to rule out any epididymitis, acute condition. Here we wrote about the extent from root of scrotum to base of scrotum. Actually, if it is very large swelling, it could extend from root of scrotum to below the level of penis. Here it is large, but it is not so as large. And here there is cystic in consistency. Cystic in consistency indicates it could be hydrocele, chylocele, hematocele, spermatocele, or cystic teratoma. Here we tested for reducibility and compressibility. What is reducibility? So in reducibility, there is decrease in size on exerting pressure and can't regain present size on own. But in compressibility, swelling regains its size or shape spontaneously when the pressure is released. So compressibility is seen in cavernous hemangioma, meningioma, or lymphangiomas. So compressibility is like emptying of fluid or blood, but reducibility is displacement of viscera. And here fluctuant indicates the swelling as fluid. Transillumination, it indicates that swelling as clear fluid, and sag wall not thickened. When do we see false negative? False negative is seen in the fluid is opaque or thick wall or elephantiasis of scrotal skin. When do you see false positive? False positive is seen in congenital hydrocele of infants. And there is no palpable impulse on coughing to rule out hernia also. And inguinal lymph nodes non-palpable. Here scrotal skin drains to superficial inguinal lymph nodes. So in an inflammation or ulcer or malignancy of scrotal skin, the lymph nodes get enlarged. Here we asked about able to get about the swelling. It purely confirms that the swelling is confined to scrotal region, because in hernia or other conditions, the swelling comes from the above, so the cord structures are not palpable. Here the cord structures are palpable, so it is purely a scrotal swelling. And this is probably a case of right side vaginal hydrocele, and it is also probably secondary hydrocele. Secondary hydrocele causes are like infection, injury, or tumor. Infections like filariasis, tuberculosis, syphilis. Injuries like trauma or post herniorrhaphy of hydrocele. And tumor like malignancies like teratomas or any other conditions. That's what. And how do you investigate this case? So we investigate this case by mainly scrotal ultrasonography is done, which confirms the hydrocele. Also, color Doppler USG is done, and routine preoperative investigations like CBC, blood sugar, RFT, LFT, serum electrolytes, blood grouping, viral markers, coagulation profile, ECG is done, chest X-ray is also done, if indicated for anesthesia. And to rule out any secondary causes of hydrocele, not necessary in this case, but to rule out, we can also do filariasis test like peripheral blood smear test or filarial antigen test, or to rule out any infection, CBC urine examination, which is also done, and for suspicion of malignancy, tumor markers are also done, but they are not required in this case. In this case, mostly it is due to trauma. And other and treatment could indicate. Why do we operate this case? So we operate this case because 5 complications will be there. Here, the burring of penis leads to difficulty in micturition and sexual intercourse. Second point is it could lead to repeated burn of posthitis, and third point is it could lead to excoriation of skin. Fourth point is it could lead to hematosphil or calcification. Fifth point is it could lead to rupture and testicular atrophy. So for these 5 points, to safeguard the patient, we do operation. What are the surgeries? So the main surgeries are, the sac is thin and small. We do simple like LOTS plication is done mainly. And if the sac is moderately thick, we do jobless eversion. If it is very thick or large fibrous sac, we do subtotal excision. Next, what are other viva questions? What are the fluid of hydrocele contains? Usually it contains it is a solution of water of inorganic salts, proteins and cholesterol clusters like tyramine. What are the character? It is a clear pale yellow amber colored with shimmering in appearance due to cholesterol crystals, and it clots due to adding of drop of blood because it is high in fibrinogen content. Thank you. So here the patient is usually examined in standing position because in supine position we can miss any hernia or varicocele. So on inspection, here you can see the swelling is present over right hemiscrotum, which is measuring approximately 10 into 8 centimeters, which is pyriform in shape, extending from root of scrotum above to base of scrotum inferiorly. So you can also see the skin over this swelling is stretched with loss of rugosities. Here you can see rugosities. Here rugosities are absent. We can't comment on the penis. And here left hemiscrotum appears normal. And we will check for the cuff impulse. Once cuff. And there is no visible cuff impulse. And there are no visible peristalsis or pulsations. There are no ulcers, scars, sinus or dilated veins. This completes the inspection. And on palpation, first we look for temperature, comparing the normal skin with this. There was no local rise of temperature and tenderness. There was no tenderness in the face of the patient, and we can confirm the inspector findings that this is a right sided scrotal swelling measuring 10 into 8 centimeters. We will measure with the tape. Approximately 10 centimeters, 8 centimeters. So this is a 10 into 8 centimeters swelling, which is extending from root of scrotum to base of scrotum inferiorly. And we can see the surface is smooth and soft in consistency. And we should check for the reducibility or compressibility. Here the swelling is not reducible, which is positive in case of hernias. And we should next test is transillumination. For transillumination, we should flash the light from the lateral side, because in posterior side if we flash, the testis gets obstructed, so we can't see the red reflex. So we put the torch on the lateral side, and we see from the exactly opposite side. So you can see the red color reflex. And next is fluctuation test. Here we should put like this. We should fix the swelling with one side, and we should do like this with other side. So as my fingers are moving, because fluid displaces the fingers, so fingers are moving, it indicates positive fluctuation test. And we should feel for to get above the swelling. For this we should put the thumb in front and the remaining 4 fingers back side, and we should move in the direction of index finger. So here I am moving in the direction of index finger. I am able to feel the spermatic cord structures. It indicates that it is purely a scrotal swelling. And cough impulse. We ask the patient to cough. There is no visible cough impulse or palpable cough impulse. And we should see for the palpation of testis. Actually, in medium to large type of hydrocele, the testis is not palpable. Here also the testis is not palpable. The left side, the testis is palpable. The left side scrotum and everything appears normal.